For the next session, can I please take the honor to invite our next chairpersons, Dr. Satish Midha, sir is the CEO and founder Vivekananda Hospital, Ranchi, Dr. K.N. Srivastav, Senior Consultant Surgeon and President, Celsi, Dr. Lalit Shah, Consultant Urologist in Chhattisgarh, Jagjeevan Urology Center in Raipur, Dr. Mandeep Sachdev, Registrar, Haryana Medical Council, to please chair this session.
Good morning, everybody. I think it's a beautiful beginning of a world-level conference. Everybody is enjoying. And in the second session, it is my proud privilege to invite our very own Dr. Pradeep Chowbey. I think he does not need any introduction. Very well known in the laparoscopic surgery world. I had the privilege of working with him in Ramanolohia Hospital for almost 5 years in the beginning, so we are at the same institute which we grew. And he is one who has started laparoscopic surgery in northern India, and many of us have learned from him what he is today. Thank you, Pradeep. All the best.
Thank you, Keshav, and thank you, the Chairperson Midha. And thank you, Dr. Mishra, and all our friends and colleagues for this great opportunity. It's good to have you all with us, and I feel really privileged and proud to be here with my presentation. And I feel that my presentation is going to be very, very simple. In last 35 years of laparoscopic surgery in India and in world, there are certain things which we have seen. And I think that my aim will be not to go deep into anything, but just to give you the flow, how it happens. We all know that, so I think, we as an Indian, we feel very, very proud that Sushruta has been the pioneer of the plastic surgery and many of the things which today we are thinking that it is coming from some other place or other country. We should not forget that Sushruta is the only person who make us proud. And also we feel that we should be sort of grateful and be proud to have him with us. Now I think we all know that the patient-friendly surgery, the surgery has evolved over a period of time, but the patient-friendly surgery is something which is very important because it is the patient who undergoes the diseases and their cure. And first of all, of course, is just imagine somebody telling that if the surgeon washes his hands and asepsis and antiseptic things are taken care of, this is the secret of preventing the complication. Today, it has become so normal for us, but those days it was absolutely abnormal. Another was the anesthesia. I think we know that previously all the surgeons used to be from Akhada. They used to have the strong 5-6 persons who will hold the patient and the surgeon will operate. Just imagine the situation and how anesthesia has really helped. Also then came the minimal access surgery. I think we and our generation is one of those fortunate, and Keshav's generation and Dr. Midha's generation have been really, really fortunate that we have seen the open surgery, we have seen the revolution of laparoscopic surgery, and also we have seen the revolution of robotic surgery, as we will be discussing. This is my slide which I made almost 35 years back. And somehow I insist to show this. It's my most favorite slide because that speaks of my mental thinking. This slide at that time took almost about full day to prepare. on the computer because everything was quite primitive. And this was a great leap of faith as a surgeon, that what I was doing as a conventional surgery, now you are just puncturing in a minimal access surgery and doing the surgery. So this was a great faith. We were not sure what will be the short-term outcome, long-term outcome, but still we were seeing those roses and we thought that it is going to be good, and over a period of time we all know that it is established now that laparoscopy surgery is the thing. And what concept was there? The ability to perform the traditional surgeries. So surgery steps were the same, but it was in a different way it is to be done. And also it is important to minimize the trauma to the patient, as less trauma to the as patient. And came the laparoscopic cholecystectomy. It is one surgical procedure which shifted from open to laparoscopy without any studies, without any conviction, without any scientific evidence. It was so obvious that it was not necessary to do any in double-blind studies. There was a famous study, I think some of our senior colleagues will know, Sheffield's trial from UK, which was published in British Journal of Surgery, which put a blind dressing of open in laparoscopy, and they proved that both surgeries are same. There is no difference in the pain. So this is the most horrible presentation and historical wrong publication of British Journal of Surgery, which is remembered for negativity rather than for positivity. Well, I think all these surgeons, I'm sure all of you are doing laparoscopic surgery, there are a lot of challenges which are put. First of all, dexterity. You have to be dexterous on both hands, left and right hand. You have to have a limited access which is showing you. Like this, you all know that you are getting a two-dimensional view and these are small tips of this thing. You cannot push too much and pull too much. So that we all have experience. But I think over a period of time we have overcome that. Lower end esophagus has become almost like a gold standard for surgery after the cholecystectomy. We talk about the solid organs. You all are doing solid organ surgery laparoscopically. And onco had a little hesitation of port metastasis, but ultimately it was proved that there is no difference in the port metastasis, and it is not logical. Over a period of time, the laparoscopic surgery is a standard way of doing oncology surgery. Of course, I will just quickly go. You have all seen that we have moved from 10 and 15 millimeter instruments to 5 and 3 millimeter, and some of the instruments have come. So miniaturization has helped even improving the causes. Then we have certain gadgets like laser, ultrasonic devices, etc. Stapling devices became popular, which ultimately added to the surgical armamentarium. There are certain devices, and all these devices I have used, and fortunately, like Anubis and all other things, did not work. Hand port, etc. We all were very happy that it might work, but it did not actually work. So they faded in the horizon. And then came all the advanced surgeries today. I think whatever surgery you are talking, whether it is in the chest, whether it is in the abdomen, whether it is in the joints, everywhere it is a minimal access surgery which is there. And you know that this Swiss knife has got multiple attachments. It depends on the specialty of the person. Well, hernia did not go that way. I think we all feel. The hernia did not move the same way. Hernia, some of you will know that the first Congress of Indian Association of Gastrointestinal Endosurgery, so-called laparoscopic surgery, was done in Delhi, and we were proud to be conducting that Congress. And in '94, I started laparoscopic hernia surgery in a big way, after gallbladder. And then we thought that let's have the opinion of this. And in '95, it was, the hernia surgery was not considered as a great surgery. The first line was, it is very frustrating surgery. Expensive, recurrence, training, guidance, nothing was available. And everybody thought that it is the industry which is pushing it. And in 2005, we had another congress in Delhi, in the same hotel, in the same place, and many of you would have seen. Now they said it's a routine surgery and it is comparable surgery. So these were, we are some of the believers at that time, which we believed that endoscopic surgery will be there. And you can see the world's pioneers on that, Kukleta, Bittner, and many others. We were just very few who were actively participating in propagating. Changing verdict, briefly, first was endoscopic hernia surgery should be done in restricted and clinical studies which are participating. Next verdict changed into that it is good repair for beneficial and recurrent hernia. Immediately it was changed that it is good for bilateral hernias, and then hernia surgery was established. Then we talk about the globosity. In 99, when I looked at the data of the Indian I realized that the obesity is going to come the way it is in Western world, and it is going to be today now established as a globosity, and we know that it is a global problem. Then came the three surgeries which you must have read about it. This is the combination of the surgeries, restrictive, which is important, and three surgeries are quite popular now. Gastric sleeve band is abandoned now, bypass, and the newer options of mini gastric bypass which you are seeing. But this is the time to change. And this is the time to change unless you continue changing your approach, your thinking, and this is the time to change. When we went from open surgery to laparoscopic surgery, the three-dimensional surgery was converted into two-dimensional surgery. And now, with the technological help, we are able to convert two-dimensional surgery into three-dimensional surgery, and that is possible with the robotic systems, and especially these systems are more dexterous from the surgical point of view, because the wrist movement, which are very restricted, are made 360-degree movements, rotational, turning left, right, everything by the tip of the instruments, which make it so comfortable. Initially, the robotic surgery was with urologists, gynecologists, and oncosurgeons, and there was a big chunk of general surgery which was not done robotically. And with if you see this graph, you will see that, OB-GYN, urology, general surgery had a very, very small percentage of laparoscopic surgery, and that was the problem. It takes a long time. See, the first FDA approval was given in 2000, and almost about 2018, it was only with prostate, CA prostate, etc. And then you see 200 to 200, but in 218, robotic surgery took off for general surgery, and now you see where we stand. These are the new generation of robots which can be shifted from one operation theater to another operation theater, and you can see the console, which is an open console. The surgeon can communicate. You don't have to put your head and neck into the console, and this makes all the difference because the patients and doctor both are comfortable. And then you have that hand grips which is there, which is much more familiar, much more comfortable to use and this is in the newer generations platforms of robotic surgery. We were fortunate to have blessed by the Dalai Lama when I started a couple of years back. When we started the robotic surgery, I wrote to His Holiness Dalai Lama because I operated him in 2008. So he wrote a very beautiful letter of best wishes. Now, what has robotic surgery at the moment? It has got a lower capital cost. It is early return to the investment, ROI, which is important for the institutions. We have a reasonable per procedure cost. Initially, the per procedure cost used to be very, very expensive. And also multiple specialties can use. General surgery can use, GI can use, gynecologists can use, oncologists can use, every specialty can use. So because of the multiple use, it has made a lot of sense. Another important point which you might not be thinking is the robotic surgery of today with the next generation robot. The port placement is almost the same what you are doing. So whatever it is, I think it's a huge advantage of getting an angle. Then came finally the artificial intelligence, which today I think everybody is talking about the artificial intelligence. And today I think Prime Minister Modi is leaving to France, and most of the discussions will be on artificial intelligence. And the combination of robotic surgery and artificial intelligence is something which is phenomenal, I think this is going to be the future where you all will be doing this. So just briefly, what is an artificial intelligence? I think it's a problem solving and decision making capabilities of human mind which are converted into a software. Through the computers it is to be transmitted. So it is not that it's coming from God, it is coming from you. The programming is coming from you. And artificial intelligence is human level intelligence. Ultimately it cannot go beyond the human level because you are the creator. So you cannot be, it cannot take over. Just a comparison, conventional software will give you a predefined output, whereas artificial intelligence will give the individualized output. So that possibly it will give you where the right hepatic artery is, where the common bile duct is likely to be there in that particular case. So it is adding to your dexterity. And it is a software which can think and decide. So this led to a machine learning. And artificial intelligence and machine learning goes hand in hand. It's like you taking a road from your home to the hospital. Your driver, your car, everything knows where to go, which direction, where are the bumps, where are the speed breakers. So something like that is, the machine also started learning. Now previously I think the benefits were, we were all thinking about the patient's benefit. We never thought about the surgical problems, because unless the surgeons are also comfortable and not suffering and are healthy with the problems produced by robotic surgery. So this has been taken care of now. I think previously the first airbag was for the driver, not for the passenger. Now there are multiple airbags which look after the driver as well as the passenger. So that means that today I think we have to change our thinking, that we don't have to only think about patients. You definitely think about the patient, but you should think about yourself and your team as well. And that is a change which we have seen. This is experience. In 21 we started robotic surgery, and today we proudly say that we have crossed more than 2,000 robotic surgeries in a very short period. And you see what happens with robotic surgery. What is important here is to see this particular arrow. This is a funnel chart for cholecystectomy. It's a funnel chart for cholecystectomy. You see, over a period of time, it is the experience. This is my funnel chart, which I have gone out of the funnel chart. That means with the help of robotic system, your surgical excellence also cannot be measured. It goes unmeasurable. It goes far, far above than what we have been doing with this. Same thing happened with the inguinal hernia. You see, we are almost here, getting just out of the funnel, because the moment I think we will do another 50-100 hernia surgery, we will be out of. So it is adding to your surgical skills. It's nothing, but these are known as funnel charts of the surgical skill, and we feel proud that in Indian, in 22 we got 2 Guinness Book records of highest number of robotic surgery in the world. So I'm coming to my conclusion. Where do we stand today? It's a very, very important question, and you have to be optimist about it. Sometimes when the Swiss knife was made, it was made with just one or two instruments in it, and today we are talking of lots and lots of robotic systems. If you really Google, there are 82 robotic systems which are in the process. It may suddenly appear with you. Many of them in the past, you see that these are the surgical robot systems which are coming in 2025 itself. And these are the diagnostic robotic systems which are coming. So we will have diagnostic as well as, and the Swiss knife will change into this with multiple attachments. However, will robot replace the surgeon? Definitely no. It will augment the surgical skills and patient's outcome in the future. But yes, this will only be possible if you have a team, because the best bedside unit of the robotic system, the robotic machine, everything is to be handled by your surgical team, your technicians. So it will not be only surgeon anesthetist team, but it will be the team of surgeon, anesthetists, technicians, technical staff, robotic staff, like those persons who will create a team. And once you have created a team, that is the success story. This I could fetch. You have seen, we created the first robotic surgery, minimal access surgery in Gangaram Hospital in 1996. You can see Dr. Kullar, Dr. Anil Sharma, Dr. Manish Bajal, Dr. Vanda, Mr. Pankaj, who is with us just now. So this is the time, I think, and fortunately we have grown over a period of time from them to this. Now this is my slide, which is almost the last slide. So laparoscopy and digital surgery, I think the center will be the robotic surgery, because all laparoscopic information can be transmitted through robot only. You need some media. So it will be, so this is a link which is today we are talking, because the future is going to be the digital surgery. This is what my thing is. So let's make robotic and artificial our friend. Do not resist, because your resistance will go waste. And India in this matter is charging ahead. Last two slides, you have to change your concept. Your patients are like a small bird like this. You have to handle your patients delicately. And if you don't handle the patients delicately, the whole concept of minimal invasive and laparoscopic surgery will be defeated. I have always maintained that operating a fellow human being is never a right, but always a privilege the patient gives to you. So please be sure that you respect that privilege given to you, and this journey continues. Thank you. Thank you very much.
Thank you, Pradeep, for a very, very informative presentation, and you kept to the time also. Thank you very much.
Thank you.
Now I'll request my co-chair to,
Sir, I request Dr. Chowbey to please be on the stage. We'll be felicitating. I request the chairpersons to felicitate. I request the audience for a standing ovation. We are truly honored to have Dr. Chowbey with us. It's truly, truly our honor to have you as a part of World Laparoscopic Association. We are truly honored. The World Laparoscopic Association is truly honored to have you with us.